So we're back in open session. Thank you for your patience, ladies and gentlemen. We apologize for the delay. What we're going to do is in a moment move your presentation up on the agenda so that you can on with the rest of your day with what's left of it. Will you hold the board roll call, please, Rosie?
Chairman Montreal.
Here.
Dr. Gabriel Cox. Here. Dr. Gallagher.
Here. Here.
Marcus Pimentel.
Here. Okay, so we had a closed session report. There's nothing to report out. We'll move over to agenda modification consideration. I'd like to suggest that we move item number 5, which is the Morehouse Common Spirit Residency Program, up to the first item on the agenda.
I'll second that motion.
Chair Field.
Yes.
Dr. Gabriel Cox. Yes. Dr. Gallagher.
Yeah. Yes.
Marcus Pimentel.
Yeah.
Thank you. So Matko, are you going to tee this up for us? I guess, sir.
Yes, thank you, Chair Friel. We have a contingent here from the residency program that we're going to be working with, or we've started to work with. Dr. Walt Mills is here as the leader of that group, and they're going to talk to you a little bit about the residency program and what's happened thus far and what we may be looking forward to. The residency program is scheduled to start in July of 2024. So they're partnering with both Dignity Hospital and Salute at this point. And also, Stephen Salyer did sign a letter of support or a letter of commitment or something along those lines. Dr. Mills, is that, you probably butchered what it was, but Stephen had signed a letter of support early on.
Okay, the podium is yours. Okay. Well,
It feels like one of those 3 or 4 day conferences and, 4 o'clock in the last one, when everybody else has gone to the airplane and you're like, "Well, I prepare." Anyway, thank you for staying.
And it's
Been going for 3+ hours now.
and in your analogy, it's 4 o'clock.
You probably know Dr. Whitley, Chief Medical Officer. Greg drove all the way to Sacramento and back today, right? So I can't complain. So anyway, you said contingent, so you're just as leader. Well, actually, I'm as much a follower as I'm a leader, and this is something that would probably resonate with all of you at this stage of my career. Servant leader is a model that resonates and that we actually teach in our residency, because that's what we need. We need physicians who are servant leaders, not just people with good ideas or good hearts, but people how to actually lead and improve and make change. So this presentation hopefully will resonate a little bit with that, because I know you're all deeply engaged in a renaissance for healthcare in this area, Phoenix Rising, and hopefully we can figure out some ways that this would support that. So I see where we at.
Yeah, we are in the middle of this PowerPoint up to that one. Power after 3 hours. I don't have a plug here for it.
So
But I have the website. I can put that.
yeah, so Morehouse School of Medicine, this is something that places on your guys' radar in Atlanta, and it's one of the traditional Black universities. They won the ACGME. The ACGME is Accreditation Council of Graduate Medical Education. They accredit any residency across the country. There are 14,000 residencies in this country. There's 800 family medicine residencies in this country. There are 80 family medicine residencies in this state. And we still are suffering from a lack of family medicine of primary care in most communities. And that's why this community was chosen by Morehouse School of Medicine and Common Spirit Health, which is now, I was told today, the largest. Today I was told that, but I've been under the impression it was the second largest not-for-profit health system in the country, Common Spirit Health. 23 states, 140-ish hospitals. Several years ago, Morehouse and Common Spirit came together and formed a new program called More in Common Alliance. So that More in Common Alliance has got a 10-year strategy to put $100 million into communities of need to make new graduate medical education programs to improve the health equity for those communities. And out of all those states, out of all those hospitals, Dominican was chosen as the inaugural hospital. So that's important in many ways. It speaks to the fact we're a community of need. It also speaks to the fact that their needs assessment showed that we are a community that can support a high-performing, quality clinical learning environment. These are very important, sophisticated leaders that were deciding all of this. And as I heard today, in terms of sharing finance, you can't just throw things around no matter what you're thinking. You have to really be thoughtful about how you're going to make this work. With a little bit of that info, this is the website, and we're going to go all the way down. That's how to get there. Let's go down, and we want it to open up.
Keep going.
Keep going. And you'll see Watsonville on the website. Keep going. Let's see, where is there's a site here for diversity, equity, inclusion, and belonging.
Right.
Maybe down the right.
Yeah.
Compensation, but maybe go up. You have to go up.
Here?
No, scroll up. Straight up. So we see what's above there. Oh, there it is. There we are. Okay, let's click on that. So. And then go down. That's right.
Okay.
All right. And so the video will be self-explanatory. You might recognize some really famous, wonderful person who's in this audience. Go ahead and click there. We'll just give you 60 seconds of it. It's a 4-minute video, but just to give you a flavor about the mission.
Coming out of the TV. Just let it play, we can get the sense of it.
I can post in all the videos.
See, there's that's about what we're going to do. 60 seconds. We're just a little taste. So you see Dr. Christina Gamboa, and we could probably end that now and go to the PowerPoint. So you have more questions? You got Christina's right here. And she is the chair of our diversity, equity, inclusion, and belonging. And when we added B to it, Dr. Millett, who was the dean at Meharry Medical School, another historically Black university, she is now the chief administrative officer for all of the More in Common Alliance, all these Mugini programs over the next decade. And she's one of my many bosses and very inspiring. And she said to Christina and I, you should add B to the DEI. You should add B. Oh, really? And I remember asking, this was a few months ago. She said, oh, well, tell me about B. She was belonging. I mean, ultimately, isn't that what we all really want? That, and I always feel like when I say it, I go, yeah, you feel it, right? So we're going to talk about intellectual things, finance things, and all these kind of things. But I think it's always really important. I try to remind myself and fumble through it all the time that what are we really here for together? So why don't we put the PowerPoint up?
So close.
Practice these. I remember what's on the PowerPoint. Sometimes it never works. And what I thought we could cover, and I've been getting coached from Dr. Cox here and also from Matco, and any questions that you have as we're going along or at the end. But we thought we'd cover just some background and then the faculty, and then we'll talk a little bit about the arrangements and the potential finances, which is intended to assuage any concerns that this will be another burden, but really to reframe it as something that this collaboration is intended to be something that raises everybody and helps you meet your missions and your purpose. So we can keep going. Great. And thank you. We keep going. So we received our accreditation as a new residency 2 months ago. We have, just to let you know, we're very optimistic. We're going to succeed in bringing the right people to this community for training and retention purposes. So far, so good. We had 680 people apply on September 27th. I opened up the electronic application system and I told my wife, oh my God, this is what success looks like. They're like, how are we going to read through all these applications? This is a good dilemma to be in. Well, we will be here on Friday for our second tour with the 8 applicants that are interviewing. We're going through a lot of that. We'll find out who's coming our way in March and they will arrive next July. And then the following July, there'll be 8 more, and the following July, 8 more. So eventually, there will be 3 years worth of family medicine residents, 24 residents in training in Santa Cruz County. Keep going.
Just a quick question, the residency program is 2 years or 3 years?
3 years.
3.
And then there'll be talk later, not tonight, but often you have fellowships, often you have other things. Often they stay on as faculty. Anyway, the intent is to have a significant number, 50 to 70% will be a target that will follow, stay in our community. And those that don't, we want them to be trained, I say, pluripotential cells, so they can go to any community in the world and differentiate themselves to meet the needs of those communities. Hopefully, most of them are meeting the needs of Turkey. So that's just, again, the website, let's keep going. And the real stories. Okay, so this is one of those many applicants that I thought, well, this would be a good one to remind myself about and share with you. So a person talking about their medical school experience, Cuban doctor, inspired to study medicine. Now I look forward to become a family physician providing the same altruistic, compassionate, empathetic care to underserved communities. This is who we're looking for. We say we're looking for residents who live and breathe our mission to advance health equity. Let's keep going. And picture does say a lot of things. So this is actually last Friday, and you'll recognize some folks there. Dr. Swears Abraham is here with us. And Dr. McAtee, you may know, Chief Medical Officer at Salud Para la Gente. Andrew Harkins, who's back up there. Andrew is likely going to be the director for the pediatric curriculum as a Stanford hospitalist. And then Dr. Angel, your chief of staff. And those are the applicants who were wandering the halls last Friday. And Matco and I will be meeting with another 8 this Friday. Let's keep going. And in terms of leadership training, boom, there you go. So we're kidding around. Is this our future board? We do want to attract leaders and develop leaders. And it was just so moving. I asked, can I take a picture? Because Matco was at the head of the board table there, and they were all questioning and answering him. And they liked what they heard. It was very, very wonderful. Let's keep going. We have a graduate medical education committee that has a voice, reports to Morehouse School of Medicine in Atlanta. This is where we have membership from our community partners to ensure that this residency meets the needs of our community partners, of which Watson Community Hospital is a big one. Let's keep going. And then we mentioned the committee, the DEIB committee that Dr. Gamboa chairs. It has oversight over everything we do, faculty recruitment, the kind of curriculum, evaluations, postgraduate retention, etc. And again, you can look at the website for more information about that. But this is another way that we've hardwired in the fact this is not a Dominican hospital only program or Morehouse only program. It's a community program. Let's keep going. Participating site, this is the ACG definition, and you'll just see this gives you a feeling about the collaboration. I, in my mind, call it a consortium, actually, an education consortium. And you'll see the many people who are involved and highlighted Watson Hospital. Should we keep going? We have a lot of faculty. We already have 60 people who are signed on as faculty of Morehouse School of Medicine appointments, and we're expecting more. And it can be others, not just physicians. And that's one of the exciting things we try to think forward about, have a multidisciplinary, team-based clinical learning and caring environment. We keep going. There's a lot of potential there with faculty recruitment and retention and development. This is what was alluded to by Matco. There are program letters of agreement that was required for us to submit for accreditation last fall. And we'll say thank you to Dr. Angel for signing on to be the site director back then. And your CEO back then said yes, and it was submitted. And then you'll see other, Dr. Whitley's site director, Dr. Kirkhart's chief medical officer at Santa Cruz Community Hospital Health Center, Dr. McAtee at Salute. Why don't we keep going? This is the flavor of all the faculty are there, just highlighted. Dr. Suarez Abraham from Salud, Dr. Susan Gamboa from Salud. You already saw Dr. McAtee from Salud. Keep going. Another list of folks who are from Salud, more folks. This is the sub-internship that we launched in June. We have 4-year students doing a month rotation here from all over the country. It's an audition rotation, so do I want to come here for my residency? And you can see these are faculty that are already investing in teaching. Keep going. Stanford Pediatric Inpatient Program. We have a handshake with a contract that's being developed by Stanford. It's just a matter of time, but the intent there is to have that consummated so that the faculty, the teachers, the physicians, and others, administration, can go ahead and have permission to start working on the curriculum and so forth. They're very close to that. Dr. Harkins and I had a great discussion last Friday about it, and so Dr. Powell was on earlier. A lot of good things happening in that direction. We have support from the director for the region from Stanford, so I'm assuming that's all going to manifest. It's just a matter of working things forward. Keep going. Collaboration. Yeah. Hopefully been a part of concretely, the initial piece is for us to have an integrated, we call family-centered maternal child curriculum. It would be 3 months in the first year, 3 months in the second year, where they would do lots of those in hospital and Salud Gente for a mix of outpatient, inpatient. Dr. Gamboa is the director for the GYN curriculum, and Dr. Suarez Abraham is the director for the overarching integrated experience. Keep going. Finance, and this is the last part. So we had a nationally recognized consulting firm that helped develop the format so we could have informed discussions about many aspects of developing a residency program. And I'll share with you what Jermaine said about it. Specifically, we have access to that $100 million. I don't know how much, but anyway, just to know that there is funding as appropriate to meet the mission of More in Common Alliance. In general, most hospitals that become teaching hospitals increase their census. I heard that with the CFO discussion today. Census, right? When I was at Natividad, where I was chief academic officer for 10 years, when I arrived, we had one pediatrician, and the rest of it was done by us family doctors. When I left, we had a great relationship with UCSF, an inpatient pediatric hospital. Natividad is now the place in Monterey County for any family, any mother, any child who wants high quality care. Not CHOMP, not Salinas Valley Memorial Hospital. It is now there. And that didn't happen overnight, but it happened because UCSF wanted to have teaching there. We needed teaching. And there was that conversation couldn't have happened if we hadn't been an academic center. So we're hoping that those are the kind of things being catalyzed by this partnership. Return on investment, again, graduates, there are good studies to show that there's about $8 million in downstream revenue for every retained graduate that you have. So, I mean, there are actually ways to model what's the return on investment beyond just the simple things that we need to put on our line items, that kind of thing, getting beyond the bottom line. Faculty recruitment. I don't know if it's happened yet here at Salud or at the hospital, but we've already had at Santa Cruz Community Health Center and at Dominican Hospital, a couple of new physicians who would not have come if they didn't know they have an opportunity to teach. That is a common situation. You tend to get people who want to teach, and it's also correlated with the quality of those individuals. You commonly get high-performing physicians who want to also teach. And then we always wonder, is it going to affect the safety of our patients? The answer is yes, it will. It'll make it safer. That's what the evidence shows, because we have incredible models for supervision and improvement, and the residents are involved in quality improvement and so forth and so on. But I always say that because 30 years ago, that wasn't always true. 2023, it is true. And that's the only way we'll run our residents. To have it be safe, something that actually improves the patient experience as well as safety. Let's keep going. So in my research for this, I came across what you guys already know, in the $300 million that was given by the HCA in California, and there were 30 applications, and there were a handful, 17 awarded, and you were awarded, and I just thought, take a moment to celebrate that as one of your early successes in this whole turnaround. And congratulations, and also to hold it out as hopefully more to come. Let's keep going. So this is the performa here, and again, MAPCO et al. Will have access. We have ways we can hook you up with all the background information about this and make sure these dollars are not missed in terms of graduate medical education. It's associated with Medicare, CMS, and I've seen hospitals that weren't well managed and missed the opportunity. And by having these larger Morehouse and More Common Alliance, people that are veterans in GME, it won't happen. And so that's what they estimate. It really depends on what the curriculum ends up being, about $150,000 a year. So I know it's only, I did my little math when I listened to the CFO report that, it's only 1/1000th of the budget, but it's in the positive direction. So we can chat more about that, but that's a piece of one stream of revenue for this whole venture here. Let's keep going. And I think this is the last one. I alluded to a lot of these. Dr. Cox sent me an email and it was brainstorming about our wish list, and I just made a list of them just to give you an idea of things like this other, right? What is other? So there was an idea about anti-racism committee funding, compensated time and general models and so forth and so on. Anyway, and I put that in here, Katie, that we have a faculty development budget. We could probably leverage a lot of things to have something like that happen. It fits with all the rest of our pieces. Training modules on teaching, new simulation materials, faculty and training professional development allocation, maybe pending, equipment. Increased services and interpretation services in Spanish and Mixteco, some capital kinds of things like getting an ultrasound and so forth. So I don't know, this has to be vetted lots of ways, as you know, but at least a chunk of it, it would feel very logical that would be something that we should be able to manifest, because it would fit with the rest of the goals and operations and stuff. So that's what I had. Happy to chat or answer questions. We go over here, so.
Got a quick question for you. Way back in my career, I was involved with trying to get a residency program going. And at the time, it was required that the hospital, no matter how big or small, had a very sophisticated and deep library that residents could access. Now, maybe it's different with access to the internet now and so forth, but that was one of the things that kept us from implementing the program, because it was expensive and the criteria to meet the certification or accreditation was pretty sophisticated and costly. So just out of curiosity, how is that requirement for medical library handled today in 2023?
Well, my experience is that the hardcover books are being phased out. The access to those are being phased out. It's now all pretty much all electronic. And we're anticipating that Morehouse is going to hook us up with all that is needed.
Okay, so that, I guess part of it would be based in Morehouse, or would it be at one of the other facilities that's nearby? If someone really I don't know if this even happens anymore, go to a library and sit down and study of something, probably not, because the internet is so accessible. But I just know at the time it was expensive for us to consider, but if there's a
Yeah.
greater access, like through Morehouse, or maybe through Stanford, or even through Dominican, some sort of a network, I would imagine, for library access would be helpful.
I can answer that too. I mean, they'll all be TV Health employees, and TV Health has a Northern California library that's online. The librarians live in Sacramento, but you can communicate with them easily. There's an online resource library, and then if you need a search done on a particular topic, you can just send it to the library and they'll send you PDFs of the articles.
Great, thank you.
Library.
Well, I have a question about resident pay.
Each at her laptop, from we know who.
Sound good. One of the residents gonna get paid is the straight up question, and then the other is about how you guys work to solve the housing cost issue.
Well, the first one's easy, the second one. But yeah, so the way residencies work is the residency pays the compensation and benefits. And if you go to the website, you'll see that. And what we did, in addition to compensation and benefits, average intern now gets about $70,000 their first year.
Okay.
And then it goes up a little bit. And then and their benefits. And then there's a housing stipend of $8,000. And that is, UCSF now does 13,000. We did a big deal and we talked to residencies, dignity residencies in Central Coast, Central California or Midwest. What, a housing stipend? Well, we're here in Santa Cruz. So yeah, but there also is a workforce housing, it's not quite mature enough to say it's a project yet, but there's a little bit of a work group that's got that in mind, both at Dominican as well as in the community. So if there's ideas we all have, that's an important part for having residents, but also for retention. Yes.
Thanks.
Thank you.
I have some other just bigger picture questions that I'm processing. The 8 residents that would show up in July 2024, are they, excuse the ignorance, I'm just to get the speed. Are they all in this county? Or are they being spread throughout other parts of the state, or is this just a program for this county?
Right, so it's for this county. So they will do about half to 60% of the rotations will be at Dominican Hospital. About 20 to 25% will be at Santa Cruz Community Health Center, because that's where they have a continuity clinic. So on day one, as an intern, you have a panel of 100 patients. Second year, you have a panel of 300. Third year, you have a panel of 400. And so by the third year, they're just like any other primary care provider in terms of the volume that they're seeing and so forth. It's just that they're only in clinic 3 or 4 times half days because they're doing other stuff still while they're in training. And then, as I alluded to, 6 months will be here in the first 2 years as the current proposed curriculum goes, which is looking more and more like it will. So that's 6 months out of 36 months. And then they will also have 6 months of what we call electives or selectives. So if they want to do advanced maternal child care, they want to do addiction medicine, they want to do global health, so they'll have ways. So that'll really depend on what that individual chooses. They may be here more. So is that helpful?
Yeah. And when they're here on this, site, who's teaching them? I mean, is that the Morehouse is paying for you guys or physicians to show up here and walk with them, or is that where does that impact them? I'm processing a lot of things. Like our big picture is no money, no mission. We're on the verge of failure for a lot of reasons, and we're trying to turn that around. We're poised to lose 5 million this year. I mean, you maybe heard that earlier today. We have, one of our biggest unions who may make a choice to go on strike, which could collapse this whole healthcare system. So there's a lot of things we're working on, and in addition to, we've got some revenue improvements that we're trying to sprint to get them in place. So I'm trying to figure out what are the impacts to us financially, to our admin team, to our operations, just from like right now, our eye has to be really prioritized on this.
Yeah.
So that we can survive and thrive and do things like this.
Okay. So in general, a program like this will be at worst a net zero. most likely it will contribute, and I alluded how much, probably not a lot as a profit center. But if the patients arrive, your productivity will go up because that's what happens on teaching services. You actually can see more people if you organize it the right way. So it will be as a minimum, it will be a net zero and more likely a little bit positive, again, depending on more things that aren't really in the control of the residents themselves. Faculty, yes, we pay for administrative work on the part of faculty who are involved in doing the evaluation, designing the curriculum, the goals, the objectives, the teaching methods, ensuring that we're compliant with everything the hospital needs to ensure that there's adequate supervision and so forth. So yes, that's all paid for. The residents are paid for, and the clinical faculty, who aren't doing anything administratively, for the most part, in most situations, in inpatient, it's just added to their service. Yeah, that's it.
Can I comment a little bit more about that? Just in case you're not medical. So residency training is primarily experiential. So as residents take care of patients, they get better at it, of course. And so they do more and more of the work. And they're always overseen by supervising physicians with privileges, or supervising providers, I should say, providers with privileges on staff. But the work, residents do end up doing a lot of our work, so to speak. They end up putting in orders and dictating discharge summaries and all that sort of thing. And so it ends up being, I found in my past work that it was a net neutral. I gave more of my time than I do now, since I don't have residents. I give much more time to teaching and guiding them through how to take care of patients, but much less time doing things like documentation, for example, because they take care of that, and there are regulations through CMS as to what is required for documentation to document that I cared for and appropriately supervised this care, but it's a lot less than having to do all of the documentation, for example. Does that make sense? Well, like we work together, and so it's it doesn't require additional time or people power to take care of the patient and to teach the resident.
Admittedly, I'm a numbers guy.
Yeah.
I've had the pleasure of serving with Dr. Gamboa on city board. I've been board member since I'm conceptually. Like I said, what I relate to is I work with the County of Santa Cruz. We've been deployed in CZU fire. We've been deployed in the 2023 storms. And in those disaster moments, we need bodies, but we can't afford to train people in that moment. So it's like, we're prioritizing, like, we need experienced bodies to focus on this. And then 2 months later, after the disaster crazy is ended, we can then deploy other people to help with sustainability. So that's how I'm related to it. And I'm just concerned about our providers, our physicians, our staff having to spend even incremental more time now, even though it's a long-term gain, but the incremental now is really important to us of not losing momentum in those initiatives we have to do in the next 6 months. Like, I'm worried about the ramp-up costs and the startup costs for us, because for 2 years from now, I'd be really excited about this. I'm excited about it conceptually. I'm just nervous about the impact, having just one more new thing to administration and physicians and our whole system of doing one more new thing when we're just struggling to survive right now in the next 6 months. That's just where I'm at. I'm trying to process. What would be so we're getting this is informational. I mean, what are the next logical steps? When are the decision points to us? When do we decide we're all in, or?
Yeah, I think,
Yeah, but I'll let you finish your.
well, I think from our standpoint, again, Salute are the ones that are working with the providers and the residents. So they're the ones taking on that burden. We're just facilitating this facility. So I don't know that, credentialing is a component. I don't know that there's a whole lot on the facility. based on what I've heard, and I mean, feel free to chime in and correct me, this is new to me, so.
Well, this might go kind of hand in hand with my question, because I heard you talk about the 155, 156,000. Kind of pro forma based number, and I think I heard you say at worst it could be 0, or break even, and this might be a high watermark, and that was driven by the volume you might get based on this program. So am I to assume that the pro forma that was done says, normally we would expect so much volume and that would come at so much net revenue, but there'd be the cost of, some extra credentialing or PP&E or whatever else goes into, providing a space for people to work. And is that really where the 155 comes from? Is what's the volume? What's the cost of the volume and the revenue that comes from additional volume?
So I'd be happy to go over like the details of it. Two things. One is we have retained a consultant from the American Academy of Family Physicians whose forte is finance. And I reached out saying, that is one of the things we want to do. We want to build this program and all the partners to have a sustainable arrangement. And so Dr. Sanner, going to have him meet with Matco, but I think, maybe you'd want to do that because that's probably the 80-20 of the whole thing is, does this work financially? Yes, mission and all the other pieces we get, but can it work financially? And so we asked Jermaine to say, hey, this is April-ish, I said, could you just put together a pro forma base, because they were doing it for all of the places. This is based on numbers from 2022 in terms of the number of patients, the volume at that point, the percent Medicare, and then there's formula that can generate that. It's a conservative number. So, and that's a good way to start. There's only an upside to it. Probably an upside to the fact that you have Stanford GME here. And I'm going to bet that there hasn't been any funding from that. And this could tap right into that. And, my guess could increase it, another, it's 20, 30, 50%. So there'd be ways to think as we get into the details, but this is the bottom. That's my sense of it. As long as you kind of keep at least the volume that you had, I think it's pretty solid, safe, conservative investment, that part.
So are you saying you would team us up with this consultant or whoever to really kind of explain the nuts and bolts?
Yeah, and I could explain it. We have, Greg and I have a lot of material that we could share and there's this little black box of it.
Yeah, no, I love it.
Yeah.
I'm up there.
So my question is in line with the topic we've been just discussing, and that is there a buy-in for the hospitals? Like in ourselves, or Salute, or maybe Dominican, so much to get into the networks with more health. And then how long is the agreement expected? Obviously, you've got people who are progressing in their training over a number of years, you're gonna want a long-term agreement. And what's the out clause if there should ever be a need to exercise one? And not that we're thinking about it, but I think what we're talking about here, we are concerned about our future. So how much does it cost us to get in? And how long would the term be? And what would it be if we had to exit?
So we actually, Dr. we had some conversations about what would it cost, and Katie probably has some ideas, and maybe others do. But what's on the radar that I'm aware of is the cost of getting the contract, which would mean you'd have to have some legal review. You might have to have some financial analysis. And I did call the folks at Morehouse on my way back last week. I said, hey, we had an estimate of $10,000 or $12,000 for legal review. And the leadership at Morehouse said that could go into our plan for startup because everybody knows it costs something to start things up. So I got permission on a phone, nothing in writing, but that would be the idea is if we kind of, what are the things that are really going to cost and how could the various supporters step forward and help with that, right? So, and we've only gotten thumbs up so far, but you're asking exactly the right kind of questions so we get down into the real serious part of things. Greg, do you have comments or?
There's no buy-in from Morehouse. lot of the costs are internal, like Julie's analysis, or there's no credentialing costs, because you don't credential the residents. The medical staff needs to know that there's residents and having the bylaws that residents are allowed. But they don't get credentialed like a fully licensed independent provider, like a physician. So, a residency training, which reports for that. So, the program covers the administrative costs of the program. Hopefully a little bit more is normal than it.
And what about the term up there? Is it a
I
5 year,
think
10 year?
I think it's a 10-year contract with the intent that.
But it would be renewed.
Yeah. I believe the initial was 10 years.
Thank you.
Our attorney Noel recommended a contract with med staff and also a contract with the facility. So it would be two different.
I have a question for you. Is the med staff independent from,
Yeah,
they're not under the hospital board or anything like that?
they are, but it's an arm's length and they're separate independent organization. I mean, it's the same as the Dominican, I'm quite sure.
Our contract would be with hospital and I think it would just be one contract with the board at our place. The contract is with Dignity Health Parent Corporation.
And we'll be able to get informed opinions that we all respect from Morehouse School of Medicine, Thomas Theory, some other things, and from this consultant, et cetera. And yeah, in my experience, the contracts with the hospital, the medical staff, you have to make sure all the rules, regulations, bylaws are consistent with being in a learning environment. You must already have that because you have Stanford residents here in terms of supervision and some of the other things that are very unique to being a teaching hospital.
So I have some questions about the program. What's new is the graduate medical education program through Morehouse. It's a brand new program, and that's what's new about it. It's just that it's
Yeah, so it's actually, they have 12 residency programs at Morehouse in Atlanta, and this is their first remote one. And it's really something that many medical schools are doing now. Like Boston University sends out 10 to San Jose Kaiser every year, and those medical students stay there. Residencies are developing. There's a lot of collaborative efforts across the country. Creighton has places, Baylor has places, you name it, any medical school now has regional places that aren't where their original medical school or residencies were. So this is one of those, and the intent is to double or triple the number of residencies sponsored by Morehouse around the country. Again, in communities of need. It's not just self-serving for them, it's really their mission to advance that country.
So that's a key aspect of is the diversity, equity, inclusion, and belonging portion of it.
I was actually gonna add something, so I think one part, again, I'm Christina Gamboa, and I'm a physician here and work at Salud, is that I think one part that as this is kind of rolled out, a very great question that people have had is, well, where are the residents coming from, right? Because we have an academic sponsor, Morehouse, and so you start to ask, well, is Morehouse bringing residents here? Are they coming from Atlanta? Like, how are we really actually having this as a self-sustaining system in our community? And so that's where it gets a little confusing, and I think it's worth kind of just teasing it out. The academic sponsorship, the vision, the alignment, the partnership is all happening from Morehouse, but the recruitment is from our local area. So as a background, our state is over 30% Latino and only 6% of physicians are Latino. And I'm making that relevant to here. We could talk about a whole bunch of other underrepresented minorities in medicine, but those most relevant to our communities are Latin person from Latinx background. And so the mission of this program is to create a space where, as we have all these efforts in our community, right, in elementary school, in high school, at Cabrillo College, we have vision for pipeline, we have nowhere for them to go locally to train and stay here. And so the goal is to have a program in our community where they can live, breathe, have it as a core of their mission and train in the community to stay here. And so the diversity, equity, inclusion comes in because we are trying to recruit, retain, diversify our workforce to meet the needs of our local community. And it's promising, right? It's all promising for what healthcare can look like here. And recognizing where we're at historically with the underrepresented representation of minorities in medicine is a topic that we talk about in every part of our building of this program. And it's exciting for the thought that it can come here because this is where we have the most need. And this is where we have a gap in the vision of what a little Latina looks like when she's young. There's no visual map of what it can look like for him or her to be a healthcare provider here. So having this as a culture in the community is such a powerful piece to create a roadmap and diversify our physician workforce and improve health equity in that way. So I know that's a big ask when you're thinking of, I know Mark well, so thinking of the dollars and cents, which makes sense. And I appreciate you guys, your time, but I can't say it enough how much all of us here and all those involved have committed to this as extra for what we do because of the alignment with the mission and the prospect it has for the health outcomes of the Buckle Valley residents. So thank you again for hearing that.
So the selection process, who's involved in the selection process? How does the application get out to people and how do we ensure that? This sounds fantastic. I would love to be able to get people from birth here in Watsonville Community Hospital to be then a physician back at Watsonville Community or Salud. How does the selection process work and how do we ensure that happens?
So there's a whole existing system through very, applications and all that comes from the medical school. But locally, we've already launched our interviewing process. It started the second week of October, And so part of my role is assuring that as we start to recruit our faculty, that there is diversity represented there, that faculty is on the interviewing committee, the way we answer questions, the support we provide about training for implicit bias, that's already been integrated and that will continue to be integrated. To answer your question about how we get it here now, we've already have students who are actually from Santa Cruz area who have done a sub-internship at Salud para la Gente who have actually interviewed. So we're already seeing that. The patience we have to have is that because it is new, it will take time, right? Like this next class aren't going to be all local Watsonville people, but the goal is in 10 years, in 15 years, that's going to be the culture of I grew up here, I went to high school here, and now I'm coming back to serve and practice. Does that answer your question?
Yeah, I guess when you said faculty and who's on the selection, I don't know if it's a committee or if it's a group or whatever it might be.
Yeah.
Just now that if this is included in our process and within our kind of web, transparency is huge for us to have that transparency of who's making these decisions and who's going over these applications to ensure that is the ultimate goal for at least our ultimate goal as part of this partnership.
Right, no, that's a perfect question to have, and our program directors are part of that screening process, but we do again have a full checks and balances of having goals of the number of underrepresented minorities we are recruiting and to actually have matriculate into the first class. Don't have to pull the cart before the horse, but one of the best reason I'm able to do this job as DI chair is that we have such a strong allyship with Morehouse, who are published authors, leading experts on DEI work. And so there will be time when the program goes where we will have environmental surveys of all the places where our trainees go. And so that's important because we then will highlight, well, what are we not doing well at, right? Where are we not doing well at in terms of areas of having sense of belonging, having anti-racism practices. And so that is one of the, for me, again, why we've all kind of aligned to do this is that there's so much potential to have experts come into our local community to shed light, which will, of course, will make us a little uncomfortable at first, but ultimately will have the payoff that our community needs to see us have a healthcare institution that is anti-racist, equitable, and where patients want to come here out of choice and feeling safe and having a sense of belonging.
To answer your sister's question, so the residency faculty is responsible for selecting the class. Yeah, so I work only for Salud, and here at Watsonville, I don't work at Dominican at all, and I'm part of the residency faculty. Dr. Gamboa also. So we're doing a lot of the interviews, and then we have other representation from Salud, Oscar Gantes and Carla Panameno. And Amy McEntee is fill in, I think. I don't know, she said she was too busy, but. So one thing they were very conscientious about was making sure we have, salute representation every day, every interview day. So salute as a proxy for representing this community.
And you have to recognize again, as I said, the numbers, there's not the numbers, right? So that there's such a small portion of our general population who are Latino, and so you're not gonna have parity at this point. But that is, even those who have a lived vision and lived experience is also the proxy that we have for those who don't have on, US Census form paperwork, ethnicity of Latino or Hispanic. So, that is the vision, is to have the faculty be equivalently representative of the community. It's just statistically impossible, the course that we've had so far in medical training to work for.
Yeah, I mean, that's like in every single profession it's very difficult to get Latinos who have studied whatever it might be, as someone who's worked in journalism, just trying to find a reporter who's a Latino who can speak English, Spanish, right, all that sort of stuff, I understand.
I was gonna build off of my experience at Natividad, very similar, we're brothers and sisters, share DNA. We over time now are close to 100% are at least bilingual, and as many as 50% are Latinx. That didn't happen overnight.
Right.
We've had GME there since the 1930s. The other piece as a board that you may want to do is, at the annual report, we'll probably have a mini GME committee kind of thing, and we'll figure this whole thing out, how it works best. But how you can reliably have a dashboard that would follow this, so you would know it's not just what we said, and look at, well, where are the gaps? Oh, great, celebrate this, but how can we improve this? That type of thing. So you have an informed way of understanding the medical education piece of things. And is it consistent with what the board, what the leadership wants?
Right. I mean, the getting more people of color and then especially Latinos here in this community on as providers, both at Salute and obviously at Watsonville Community Hospital is important to us. I think the other thing that's important is the retention rate from a program like this. And I don't know if there's something similar, maybe like a program. I know it's new, and but if there's anything else similar like this that you see good results from this, and maybe even a question for our team, and just
Yeah, well, I would just say that so we just hired a graduate of Natividad and has hired others, and that's our intention, is that in a few years we'll be saying, oh, great, we just hired so and so and so and so who graduated from the residency. Same thing, I just visited the Santa Cruz County Health Department on Emmeline earlier today about a shared project that will work with our collaboration. And they said, oh, do you know so-and-so? And that person was actually my advisee when I was chief academic officer at Natividad. And he had talked about possibly coming here, and he actually signed the contract. So anyway, there's a lot of reasons why this should just make it better and bigger. We mentioned housing earlier.
Yeah,
Probably the major thing.
yeah, people don't come work here unless they love the area, unless they, as I'm sure, just seeing your background or hearing about your background. Watsonville's not a destination community, so to speak, at least not, as someone who grew up here and raised here. I mean, you don't stick here, you don't live here, you don't work here unless you love it. So that's, huge in terms of getting that retention and holding on to nurses, doctors, all that sort of stuff. So.
Well, to quote the general number of 50 to 70% of residency graduates stay in their local community. I don't know if there's data on new programs or, programs in with these demographics, but I think when you finish residency training, comfort is
Totally.
pretty important. And so I think people, and Watsonville is an amazing community, and so I think people, when they come, they will fall in love with it and will stay, even if they're not from here. Which is going to be the initial group is not, as we pointed out, going to be people from Watsonville.
Yeah, we love transplants as long as they respect the community, definitely. Okay, I have several more questions, but that's okay. Thank you.
Can I ask one other different nuts and bolts question? Are people gonna do internal medicine, adult internal medicine rotations in Watsonville Hospital, or is that all at the minute?
We talked to Dr. Angel about it,
Yeah.
he gave a tour last week, and, he walked everybody through, the adult medicine and said, well, and he mentioned, well, we're not sure, but maybe sometime. We'll see. Anyway, it's not, in our initial draft of things, we shared where we're at, but it really depends.
Good enough, thank you.
My guess is there will be a subset of people that they will have their emphasis on hospitalist medicine, and they're gonna wanna have people like Dr. Angel as their mentors, and so, my guess is there'll be some, but,
Thanks.
What's next? So this is information only.
Yes, informational.
Yeah. Well, we got a lot of it tonight, so I appreciate that.
Can I get back to the, when do we decide?
Yes.
When is the decision?
So an affiliation agreement would be forthcoming, correct? For the facility.
as long as there's thumbs up, go with it. That was our intent, but now we'll start reaching out to all the folks that need to be involved in generating.
I mean, I'll be candid, if I'm voting tonight, I'm saying no. And it's, I love the program, and it's $8,000 an hour for us. We already spent about $8,000 an hour in lost opportunity costs, because to get our initiatives done, to solve an $8 million gap next year, takes your time, our time. And this is, again, it's not a negative about the program, and we have to do this work so we can do these programs. So I'm not ready to commit any of Julie's time if I'm deciding to be reviewing contracts, or your time, or BPK's time to do this work. Right now, it's not our biggest priority, it's the community's biggest priority. I agree to that, but without a hospital here, our whole system fails. So that's, I just wanted to put that out, that's where I'm coming from.
I see it quite differently. I'll just say
Go
that.
ahead, or-
Well, I think residency programs lift the whole academic, intellectual environment of practicing much better medicine. I think it's something we sorely need. And I think the recruitment of future primary care base, which we no longer have, is a huge, almost insurmountable problem, which they have a solution for. And I think our posture ought to be, how do we get through whatever startup hump? Because the benefits are so extraordinary, is really, I guess, what I think.
And if we're closed in July, then there's nowhere for them to come.
Pardon? I
So-
didn't hear.
more information. Marcus was just making the point that we, sustainability is essential for us, so we need to focus on sustainability. Without that, there's no point to discuss the residency, so.
So just a comment, I think I understand what Marcus is saying, and he's right. Or I don't agree with him, because sustainability is way out in the future. This is kind of the future, and the success of the future, I would hate for us to be sitting here a year from now saying, damn, I wish we took that opportunity, because we would have this kind of position on this kind of level. And I think programs like this raise everyone, from the nurses to the technicians to the general staff. They feel good about participating in medical education, and the people that come here to be trained bring that level of enthusiasm. Right, my suggestion is that we ask for that contract, and we put the energy and resources, whether it's Julie and her team or yours, either the board members and legal, to take a look at it and bring this to the next level. I think it's too soon to say no.
I would suggest that you send all bills toward the residents. I mean, it's, like any cost that you see as incurred because of this endeavor, that you send the bills, and Dr. Mills will be in contact with Morehouse about, hey, your startup cost, you said you have startup costs.
I think our challenge is their opportunity costs, they're not direct costs, right?
Sure, yeah.
When Julie's not solving our budget and financial position, and MACO isn't working on the new agreement, then we're not collectively working on bargaining agreements. We're doing other things, it's just diverting us from the stuff we have to do to be here in July. And I think if we're having this conversation in May, it's a different timing than if we're having it in October 2023. We're so close. So that's just where I'm coming from. Again, this is just, I want to be very candid, we're struggling with what I'm feeling we're struggling with.
All right, so once again, this is informational, and we'll follow up with some more information. Thank you all for your,
Yes, thank you for bearing with us on the late night.
thank you for
Thank you.
hanging in there. Appreciate it.
We're right back.
Well, we can continue. So let's move on to the agenda. It's almost tomorrow.
Thank you.
Are there any public comments online? Okay, so any more comments from the board?
I do.
Not hearing anything. we'll move
Oh,
on.
no, John, I do.
Sorry. Yeah.
I appreciate the opportunity cost analysis, but I think this is,
All due respect, we moved on from that item, so we should be discussed. I don't want to be dismissive. It's raining when we can talk about things.
Well, we're in the we're in the comments from the board.
Oh, we're still on time for.
Yeah, so Joe, did you want to finish it?
I do, I think this is the best thing I've seen happen in years. And I think would be a mistake to sign ourselves out of it. I think it would leave us in an extraordinary position in the county to not participate in this. And I can't emphasize how difficult future recruitment is. Some years ago, when we were trying to recruit, Kaiser hired 50% of the family practice residents at that point, and now there are other systems. And so I think trying to rebuild, and I appreciate that where we're talking about the cost is shorter term and not talking about longer term. I think recruiting is going to be a very difficult situation, and here is a very good solution. That's what I'd have to say.
Julie?
I mean, I think if I could kind of chime in, just knowing
Either we.
what I know is what I've heard tonight, you know, that's like the full extent of it. But
I just want to, just from process, if we're gonna dive into this, I'm okay with that. We need to reopen the item and I closed it, so we're in a quandary of process.
Well, if you talk about the agenda, we're on board comment period.
But we're now in discussion though. I'm just. If Noel's here, she's saying you've moved on from that item. The discussion on that item should be done.
Technically, board comments was prior to any agenda item.
I'm just talking about process. I'm not trying to be rude. I just want to recognize.
we can just have offline and individual conversations.
Okay, so let's move on to consent. Several items on the consent calendar. You'd like to make a motion?
Yeah, I'll move to approve. Chair.
I'll second, and I'll just note that there's a cosmetic correction in the July 26 minutes that Rosie and I talked about.
Yeah, we will approve the motion as it states, aside from a quick update to the minutes from July, which states that the bond approval will not be with dictates, forming an ad hoc date. It was formed and it is in this. Sorry, we have
Okay, so you want to pull the board then on the consent?
Tony than me.
Tony Berkman. Turner Brown,
Yes.
Dr. Cox,
Yes.
Dr. Gallagher,
Yes.
Tony Dingus.
Yes.
Yep.
Okay, moving on to number 3, then on discussion is bond measure status. Matco?
Sure, Marcus, do you or Tony want to comment or give an update on the ad hoc committee? Or
I think it's a short and brief, where the committee's been meeting to explore if and when to bring a ballot measure in 2024, and we're still doing our due diligence and research and expect to come to the board at the November meeting.
The question, what's the deadline if we were to go to the March ballot?
December 8th? December 8th.
It's our November meeting. That's
Yeah.
false. Well, it has to be our November meeting, it has to be a regular schedule.
Do we know right now what else will be on the March ballot? Is it a primary ballot?
It's primary.
It's presumptive, but there's a lot that's gonna be on the 2024 election cycle. There's a lot of initiatives.
When's the PV November?
Right. I think they haven't decided yet.
Yeah.
So everybody's still speculating. It's too early to say who's doing what when, and that's a dangerous spot to be for us. But right now, we're just exploring our best options.
And once again, we just have to get 66 or 2/3 of those voting.
Yes.
And is it typical that March ballots generate less of an outcome than November? And given
There's less turnout typically for the primary election versus the general election. But with the polling that we did, it didn't indicate one versus the other. It polled pretty equally. You know, sometimes according to John Isom, it'll be obvious you should go, you know, during a general election versus the primary, but across across everything, it kind of polled evenly.
And
I'm just concerned that, you know, with it being a presidential election, healthcare is going to be one of the top items that people will be getting lobbied over, and here we are asking for a significant amount of money for them to consider, and they say, well, my costs are going up over here already. Nobody's doing anything about it, why should I vote to catch myself? So I'm just thinking that if we can see an advantage to going in March, it gives us a shortened period to campaign. But it might be the best way for us to go, but that's some of the things that folks are working on, I'm sure. But
a lot of very robust discussion next month,
Yeah.
and you're making a really good point. Tony, anything else?
No, just that, the end of November will be, like Mark said, because the decision has to come at a regularly scheduled meeting. And so, November will be the day that we'll, staff will bring something forward before the board from a recommendation from both that, from Marcus and I and the IADA committee. And that'll be kind of the decision date for us of where we're at for March, whether we believe is a better opportunity for us in November. And so we're weighing all those things and looking at the landscape of the community right now, because there will be, you know, on top of the presidential election and obviously some of the county supervisor races, which, you know, can sometimes be contentious, contentious, even if they very, you know, they barely graze our district. But there will be a lot of things on the November ballot. And so there's a lot of things to discuss. Just a lot of good conversations we had in the upcoming ad hoc committee meeting.
thank you. Move on to item number 4, which is presentation. And June, we're gonna get all the money we're gonna need forever.
This is a good time. We're almost there, guys. We're almost there. I'll try to make it short, brief, and to the point, and let's roll. Yes, I'm hungry. This Swedish fish helped me for just a little bit, but now I think my husband's watching. Honey, warm up my food.
We're all coming over for dinner.
All right, so this is just a third quarter update, just what the Watsonville Community Hospital Foundation is up to. It's a working document, nothing is firm, everything is evolving, just like our organization, but all in good spirits and in good purpose. Next slide. One of the key things that the foundation is working on in the next couple of months are a few things. Just like the hospital completed their audit, I am in the middle of completing our audit for our 501c3. It goes from 2021, July 2021 was the inception of the project, now the foundation, and up to 2022. I'm very happy and pleased that we are so close, and we anticipate having something by the end of the month or in the next week or so. Very happy about that. The other thing is growing our foundation board. Of course, we're a new foundation. We weren't built as a foundation, so there's a lot of structural growth that needs to happen. And just call it a year of growth and making sure that we establish ourselves for the long haul. The other initiative that we're trying to initiate a strategic plan for our foundation to best support and align with the strategic plan of the hospital. In addition to that is a development fund plan so that we can strategize, work together, and really create that synergy between what our goal is as a foundation and making sure that we support and provide access to care to all the patients that come to Watsonville Community Hospital and our greater community. The other thing is that what we're planning is a quarterly newsletter. We will probably, most likely, we're working on one. A simple newsletter, e-newsletter to go out at the end of the year. And we are planning on doing a year-end appeal. We'll be highlighting a Safe Start program, which next slide, will explain a little bit more about the Safe Start program. So the Safe Start program is a program for babies and moms here at Watsonville Community Hospital. Essentially what we did is, there was the needs, a capital needs, and I'll share the list with you. There's a capital needs that, a priority list that the hospital has developed. It's a large list of 3 pages of Excel sheet. And from there, we are assessing what are the top priorities. And here are some of the top priorities. There's needs for birthing beds, there's needs for a microscope, there are needs for warming beds. This is only a snapshot of a short program that some of our local funders have asked, June, what can you give us? How can I support or have our donors engage with, what do you have? What's your menu? What can we have our donors support the hospital with? So this was created because of that. Because we want to create a human touch of, it's a microscope, yeah, but what does it do, right? It's providing that human touch and feel to the equipment that our hospital needs. The equipment list is big, but we're taking small bites, and this is one strategy of what we can do moving forward. And the ranges, they range from 15 to 9,000 to 250 to, it depends on what the donor would like to do. Mainly, we're trying to capture year end. Next slide. So there's a couple areas where the Safe Start program fits in. I'm calling it areas of impact. Just like we had the Safe Start program, which focus on babies and moms, we're gonna have a similar plan for our cath lab, right? To launch our cath lab requires a lot of needs. Equipment, investment on training, investment on growth and training of our of staff members. So again, part of the plan is to create a menu and a program that perhaps when I meet and talk to potential donors, I can provide them with an array of menu and areas that they can support. Same thing with building an equipment program, right? Emergency room expansion, technology improvement, electronic healthcare records. Of course, a lot of that conversation is also involved with the bond conversation, potential uses of a bond, but I think it's important to put it out there and start letting our donors and community members know what are some of the needs that we have in our hospital. And then of course, there's the area needs, greatest needs fund. For that, education, equipment, training. What happens if we have another pandemic? God willing, that does not happen. Flooding, earthquakes. This is where we set up our emergency funds. Next slide. The list that we were talking about of where these programs arise was because of part of this priority capital list that was developed by the hospital a few years ago, right? So really what we did is we captured the top, I'd say top 20 list of priorities. And this is your list. Again, it's a working document. There may be things that we may need to add, remove. All are part of the growing of the expansion and discussion. What you see on your right is an estimated amount of cost. And the total amount on this particular capital list, you can't see, but I think it's about $4.9 million, which is quite a bit, but we can only try to share the narrative and start sharing with our communities. community members and donors. These are some of the needs. So that's why there's a program. We're trying to add a component of extracting the needs for the specific equipment. Next slide. Aside from doing equipment needs, service needs, the big component is community impact. What programs are we doing to not only serve the patient when they come and visit our hospital? We gotta think big. And big, but also attainable where it's cost effective, but we also lean on our partners, because that's where we're about. One of the programs that we are initiating is the Healing with Art. How do we incorporate local art and create a space of healing environment and welcoming to all our patients, all our providers, and our guests? The key is to partner with local organizations such as Faro Valley Arts, Art Council, Watsonville Film Festival, and additional community members so that we can develop a plan, an art plan, to see how can we engage, how can we provide local art, and really share that within the community, to bring in the community from the outside and have them come to our hospital. Healing comes in different forms. It can be through art, it can be through music, it could be, you know, we have many empty walls. This is a perfect opportunity to allow for our patients to, and our community to engage with our hospital. Then, as Matko shared earlier, the Nourish program. The Nourish program is a program in partnership with the Second Harvest Food Bank. The key is a pilot program for mothers and babies that are born, the babies that are born here at Watsonville Community Hospital, but to provide the pre and post and nutrition education to the mothers and the families. Again, we provide them the service. Yes, their babies are born here, but the impact is much greater than that. I think we are all aligned with that. That's why we lean on our partners. Second Harvest that's what they do. They provide nourishment, they provide education, they provide access to food. And the key is, once the family has their babies here, they can walk away with the nutritious food, and they'll have a basket with beautiful produce, and so that they can go home and feed their families and make sure the mom has the appropriate nutrition. But it's providing that warm handoff to the parents, the mothers, so that they can continue receiving, if they do need additional nutritious education and access to food. Second Harvest will be that warm handoff. Second Harvest, we've been in conversation multiple times. We're still working on the details. We're having a meeting with our providers in the next couple of weeks. We are also planning on hosting warm reception, or just a sneak peek to potential funders who can help fund the program. And we will use it as an opportunity to engage them with Watsonville Community Hospital and learn about the different services that we provide here. So I think it's a window opener, or a door opener to what we as a hospital have to offer. Next slide. One of the things for the foundation is how are we accepting gifts and contributions? One of the biggest things is that internally, we do our own grants. We seek our grants, we apply for grants, and we actually have support from our staff members who help us share the narratives and share the stories. I am very proud and pleased to share that in the spring, I submitted an application to Monterey Peninsula Foundation for $250,000. I just got the letter yesterday indicating that they are going to provide us and grant us $250,000. That money is going to be used to purchase 4 anesthesia machines for our OR team, so that we can ensure that we provide that safety and just provide our surgery. So we're really,
Yeah.
we are excited about that. Thank you. We also have the employee giving, physicians giving is still on queue, and monetary contributions. One of our key partners is Santa Cruz Community Foundation. They're helping us on accepting gifts of real estate, bequest, charitable trust, insurance, stocks, bonds, corporate partnership. They are critical in the support and infrastructure of the foundation. And we're just, like I said, it's the year of creating the foundation for future contributions. Next slide. So in 2024, what we look forward to is to have an annual gala silent auction event in September, October of this coming year, next year, I'm sorry. But it's to honor and celebrate when we became a community hospital. We intend to have quarterly donor events, small, not so big, but enough to engage with community members and anyone who's interested in learning more. Meet our CEO, meet our medical team, but really make those events so that they get to know the hospital on a personal level. Donor newsletters and appeal, and again, continue to grow our donor base and community partnerships. One of the key things that I have seen and have participated is working in collaboration with many of our community partners. CAB, Community Action Board, Community Bridges. There's multiple, there's a collaborative effort being done here in the city, within the city. We're all leaders of the different organizations. We get together weekly, every Wednesday, and we discuss what are some of the issues that are arising within the Pajaro Valley. How can we support each other? How can we engage? How can we partner? How can we do collective work so that we as a collective group, organization, start working to ensure that we have access to healthcare and other issues that affect our community. So in a nutshell, is that the end of my slide? I think it is, you guys, it's the end of our slide. Any questions?
Thank you. Thank you.
Yes. Okay.
Great update. Not just the news, but I appreciate the update.
Oh, good.
Your news on top of that.
Yeah.
Yes.
I was about to, we got a acceptance letter as well too, and I was gonna text you, I was like, oh, maybe June got one, so I'm happy about that. Seriously.
I am.
And June, how big of people?
Monterey Fields Foundation gave $250,000.
We had one who resigned, we are expanding. And that's one of the key things. We just hired a consultant to help build the infrastructure. There's interested, the board developed a list. I'm actively meeting with them and seeing if they're interested in supporting our board and supporting the hospital first and foremost. And just believing in what our goal is. So it's a work in progress. Of course, they want updates on the hospital. They want updates on what does it mean to be a foundation board member? What's the time? How much do I need to raise? So all those details. We'll get there. We've got a good group. I've got some tentative yes. It's just completing the process.
So with the program with Second Harvest, you said that you guys are gonna try to get some funders to stand that program. That's the same food pantry program that Matt was
Yes.
talking about. Do we have like a specific like seasonal ask that we would want to have that, or do we have startup funds for that, or?
So the funds, Second Harvest is supporting the first initial year.
Okay.
So, and there's been conversation of how do we approach and seek grants together.
Yeah.
There's a lot of conversation of health and nutrition and, health begins at home. So there is opportunities. Many funders have also expressed so much interest in that particular program. How it unfolds, that's yet to happen. It's on its way. But also keeping in mind that the different data points and that we want to capture as an organization are important, but also to share information within our community. Those are, you know, that's still in the works. But so far indicators have been, their board is fully aware. The foundation board is aware, you are aware that this is happening. And so I think there's a lot of movement behind this. And there's been studies, and I've received information from the school district that said, yes, you're on the right path. This is the way to do it. It's making sure that we reach the community and our patients where they are. And how do we facilitate and create that synergy and partnership? And this is only one model that we can expand. What if it's seniors, right, next year or the following years? What if we focus on other sectors of our population? So it can go multiple ways. How does this go with Semillitas, right? With Maria Cadena's group, right? With ventures. The county has been supporting. How can we align? So it's thinking bigger for the patient, thinking how can we best support the patient? And how as we as a hospital are the vehicle and the venue to convene all these different organizations to provide what's best for our patients.
Yeah, definitely. The ask is just so, anything like nutrition based, the ask is so clear and so, I don't want to call it low hanging fruit, but people love that idea of nourishing, I like the name of it, nourishing children and families. So Giving Tuesday is too quick of a turnaround, right? To make that the ask. Although who knows, June, you do some incredible work, but I feel like that's like a really great ask for our community of like, help us make this thing sustainable, right? So that it's an additive to the hospital, it's additive to the community, have the community really invest into it. I think it's a great idea. I'm super excited about that program. The strategic plan, June, are we still like in the kind of just beginning stages of that, or do we have like a date?
We don't have. The key is to grow the board.
Okay.
Come January, and I think we're still initiating that conversation. What comes first? You know, of course, we need the board.
Right.
We need a sustainable board, a big board, to help us create and develop these initiatives in coordination with what the hospital is doing. So I anticipate, again, 2023 was a year of infrastructure for our foundation. I am actually really surprised. I'm grateful for Monterey Peninsula Foundation. They awarded this without having an audit. I mean, we don't have that's big. That speaks loudly for this hospital that they believe that we can do something good. So it's en route. I think 2024 is our year.
Fingers crossed, and you never know unless you ask, right? That's what I thought.
Oh, well, always, yeah. You want to meet with me? It's gonna cost you $500,000. Any questions?
I have one other question. I think, Matt, I asked you this, about surveying Silicon Valley for potential donors, and you told me there was a consultant. Is that all? So
Yes.
June, is that sort of at the very beginning, or kind of where are we in
Yes.
that piece?
I had a board meeting last week, and the board and I agreed to hire Patricia Gardner. She is well respected in Silicon Valley, has worked with many organizations and healthcare districts also in Silicon Valley, and is well connected. Big
Thanks.
thinker, she has worked with bonds. She said, June, I have sat in your seat. Let's make this work. I know where you're at. Let's lean on our partners. Let's lean on what has been done and my experience, and so, we're excited to be working with her. And her connections to many of the organizations in Silicon Valley is a plus. And she's done some work here in the area.
Her name Patricia.
Gardner. Thank you.
Any questions for June? I think we're at the end of the agenda.
We got the- So if we're on item 6 in the audit, we have a clean audit, we have a clean internal control, we received the full presentation. The entire materials are in the packet, we reviewed the materials, we discussed it in the finance committee, the finance committee recommended that this board accept and approve the financials.
I couldn't have said it better myself.
I'll move staff recommendation.
Second.
Chair Brown,
Yes.
Dr. Cox,
Yes.
Dr. Gallagher.
Yes.
Director Daniel.
Yes.
And Director Pizarro.
Yes.
Okay, now we're at the end